All right, I think we're going to get started as more people filter into the discussion today. And I wanted to thank everybody. It's been a few months since we last met here on the Center for Indigenous Cancer Research at Roswell Park's Talking Circle webinar series. And there's many reasons for that. I think it was a good time for all of us to regroup and establish the service that we're going to talk about today, which is our Rural and Indigenous Patient Navigator service. And I think there's maybe some misunderstanding, or maybe people have not even heard of patient navigation exactly. So our panelists today are all from all different backgrounds, and they're going to describe to us what patient navigation is in the context of cancer care and the different aspects that go along with that. So because we have so much content to cover today, I think we're going to get right into it. And so what we're going to do first, and I think it's important to provide context because our guests today have all different backgrounds. They've been from different places, they come from different places, have different education and backgrounds. And I think that's important to highlight too, in terms of how they deliver patient navigation. So in no particular order, I'm just going to start from left to right. We're going to do some introductions and maybe a quick, short, brief bio about yourself as well. So we'll start with Renee Fiersdorf.
Hi, my name is Renee Fiersdorf. I'm an enrolled Seneca, part of the Deer Clan. I have a background in health information management, which, if you're unsure what that is, it's basically medical records. And then I have a master's from the University of Oklahoma, a master's of legal studies in healthcare law. Sorry, that's about it.
All right, Chelsea Redeye.
Hi, I'm Chelsea Redeye. I'm from the Walker River Paiute tribe in Nevada, and I'm also from the Cattaraugus Reservation. My background is in psychology and anthropology, also with a little bit of sports recreation thrown in there.
Nancy.
Hi, I'm Nancy Carrier, Mohawk Turtle Clan. I graduated last year from D'Youville College with my bachelor's in health analytics. I spent most of my years in the gaming industry at Seneca, Niagara, and then I transitioned over into healthcare. I grew up in Niagara Falls, and I was kind of raised traditionally in an urban environment, so it gives me good understanding to know the people around me when I'm working over in this area.
Marissa.
Hi, everyone. I'm Marissa Herring. I am from the Seneca Nation. I'm Wolf Clan, and I grew up on the Cattaraugus territory. I have a background in health education. I was a health educator for about 6 years before coming to Roswell. I have a bachelor's degree in community health, and I recently got my master's degree in Native American leadership, and I'm also a health education specialist. So that's a little bit about me.
Thanks everybody for those brief bios. And I just wanted to mention, this is not a representation of all of our navigators in this particular program. I think that because it is Breast Cancer Awareness Month, and we have some of our female Indigenous staff members, we wanted to highlight their work specifically and how that relates to breast cancer in Indigenous communities. And so I think there's a lot of ways we can tackle this particular topic. And so I think we'll take a semi-formal approach, but feel free to chime in if you have any additional ideas to the following questions I'm going to ask today. Okay, so for the first question, from your experience in the field and at home in the community, what is a patient navigator, and why do we need patient navigators? Chelsea, do you mind tackling that question?
Yeah, I think at the most simplest level, a patient navigator is an individual who is working with a patient through different stages of the cancer journey. So that includes prevention, screening, and diagnosis. And why do we need patient navigators is because we've seen through many researches, even talking face-to-face with different community members, that cancer is a big problem within our Native communities, and we need an advocate. We need an advocate to help people get the resources that they need.
Great, that's very concise. Yeah. Renee, what do you think? What are your thoughts on that question?
I have to agree with what Chelsea stated, what a navigator is. I wanted to add too is that not only are we there with their cancer journey, but we're also there with them through survivorship and after, having successfully beaten cancer.
Yeah, and to build on that a little bit, the navigation program is not that uncommon. There are other navigation programs across the country in different contexts, and it's a pretty well-researched form of service for cancer patients. And anybody that has experienced cancer or anybody that's been a caregiver of a cancer patient knows how complicated, complex, and stressful it can be. I think at its fundamental level, navigators are there to mitigate or lessen some of the stress, the additional stressors a cancer patient might face financially, psychologically, physically, and the navigators, among many things, because I believe it's the most critical service that we now offer at the Center for Indigenous Cancer Research is to fill in some of those voids that happen. And there can be oftentimes sort of cultural voids as well that the navigators can fill for our Indigenous community members who are receiving cancer care. So this is an extremely exciting and critical part of the Center for Indigenous Cancer Research. And I think that as our navigators move through their respective positions, they're going to help this program evolve from what it is today to what it's going to be in the future. So their work right now is extremely critical. The next question I have is with breast cancer, with October being Breast Cancer Awareness Month, can you all share with us the importance of breast cancer screening specifically in our Indigenous communities? We'll start with Marissa.
Yeah, sure. So breast cancer screening, like mammograms and breast self-exams are extremely important, especially in Native communities. Unfortunately, for Indigenous women, breast cancer is the second most common cancer death. So with mammograms, you're able to find the cancer sooner where it's more easy to treat. So most people who actually find breast cancer, they find it before any symptoms occur other than maybe your healthcare provider finding a lump or something comes up in the mammogram. So usually the mammogram is the best and earliest way to find that cancer. So mammography is really, really great and it's important. It actually saves lives. So if people follow their routine mammography schedule, it actually reduces a woman's chance of dying from breast cancer by 30 to 50%. So it's, it's critical, it's life-saving, it's pretty quick and easy. So during a mammogram, it's really kind of like an x-ray of your breast. So what they do is they put two plates and they kind of put your breast in between the plate. And then they do it horizontal and then they also do it diagonally. And then they look at the image and they see if there's anything that's abnormal. Usually if there is something that's abnormal, they're gonna send you for further testing. I know it can be really nerve-wracking to get a mammogram and maybe hearing about some abnormal results, but a lot of times, maybe those results aren't cancer. It could be something less serious, but like something that's benign, but it's really important to follow up and find out what that result is because it can be cancer, but you wanna figure out what it is to help treat whatever it is.
Great. And Renee, if you have anything to expand, I think that was a really great answer, but if you have anything additional to expand upon the question and also maybe fill us in on the typical age, the age recommendation for mammography and breast cancer screening.
Yes, I think what Marissa said was really great. Honestly, I'm really drawing a blank on the age of when you should begin screening, but they do recommend screening younger if you do have a family history of it. If you do start feeling, once you're doing a self-test, if you're feeling lumps, even if you're a young adult, early 20s, there's no issue with getting a mammogram. The higher the chance of, self-detection, you're able to, forego having that cancer diagnosis. But I think what Marissa highlighted on was really, it was really great, very insightful, and it targets everything that, should be done to prevent breast cancer.
Yeah, and I think that like many cancers, is the screening ages can differ, whether colorectal cancer, breast cancer, the standard ages are now becoming younger and younger for those screenings, but breast cancer starts at, I believe, age 50. And we've seen in colorectal cancer that was the case. Now the age is being lessened to 45, and that's alarming. And there's many reasons to believe why that is. What's most often assumed is that it's bad luck, but it clearly is not just bad luck. It likely is a product of our environment, and whether this, we can go down a rabbit hole here, and I want to avoid that because it's a really interesting and an important topic that we're going to cover in the upcoming months, actually, with the role of environmental exposures and the risk for cancer at younger ages. Yeah, absolutely. I think that that's a really important takeaway, is that your family history is important, your exposures. It looks like we have a comment. 40 is a standard age, depending on your provider, for those breast cancer screenings. All right. So like I said, the age recommendations seem to be a little bit, so it seems to be a little continuity issue there in terms, and I know that even Indigenous health organizations will recommend screening at younger ages than the typical standards. And so we certainly want to talk to your provider about those screening ages.
I can just chime into a little bit about the screening recommendations. So it is recommended once you're 40 and older to have it once a year, but starting at age 25 or even younger, if you want, you can start doing the breast self-exams, and also talk to your healthcare provider about that cancer risk. One of the biggest risk factors for breast cancer is having, a mother or sister who had breast cancer or ovarian cancer. So if you do have one of those, it's good to get recommended at an earlier age, and also for like a genetic mutation in your family, like the BRCA1 or BRCA2 gene. So that's a really good conversation to have with a patient navigator or your healthcare provider as well.
And I just wanted to mention this for Marilyn, who's in our chat discussion right now. I want to ask you a question, and let's save it for the Q&A, but you mentioned there's various recommendations for starting mammography. And I'd like you to maybe speak on behalf of why there are various recommendations. What are some of the reasons, rationale, why there are various recommendations? And if you want to put that comment in, or maybe I can ask you at the end, we can tackle that issue because that's important as well. And so moving on to the next question we have on our discussion today is there are many ways in which our communities can actively prevent breast cancer. What are some of the most important ways that you feel that Indigenous communities, and screening is obviously the lowest hanging fruit, so feel free to discuss that further. But if there's any other ideas that you might have about how we can, as our communities, prevent breast cancers, and in generally speaking, there's many ways in which we could collectively prevent cancer. But Nancy, what are your thoughts on that?
Yeah, the obvious is to start early and consistent screening, with breast cancer, doing the mammographies, and then spreading the awareness of the importance of screening within the Indigenous communities, getting the word out there and talking with community members and educating them about how important it is to get your routine screenings done. There's also, your lifestyle, exercising and your healthy eating will impact you tremendously to fight against not just cancer, but any other chronic illness. If you're a smoker, try to reduce or at best quit and reduce your alcohol intake. And also it's recommended for women who can bear children to breastfeed. It's one of the most powerful tools we have as women, not only to nourish our children, but to help fight a chronic illness.
And Chelsea, what do you think? What are your thoughts on that?
Yeah, I think what Nancy said was correct. Like we can be doing so many lifestyle changes to help increase or decrease our chances of breast cancer. I just wanted to add, when we talk about screening and talking about those annual screenings and why they're important, is because the first screening is the doctors looking at what your natural tissue would look like. The second screening, the third and fourth after that, is using that first screening as a baseline. So that way, if any abnormalities do happen, that your doctor can look at the first one and then evaluate off of that one. And I think we talk about screening so much, but really it's why. It's because we can see those changes, and it's those changes that sometimes do affect, can make cancer.
So as we're talking, I have a question of my own that I want to sprinkle in the conversation too. So, we mentioned the importance of screening, why we need navigators, and I think some of those are self-evident. And this could be a question that relates to all women, but for the context of this discussion, what are the challenges what are the challenges for Indigenous women, or what are some of the barriers that you have seen, that you've talked to community members about as being barriers to getting screenings? Marissa, what are your thoughts on that one?
Speaking from, I guess, just what I see in the community and hearing from different community members, I think around cancer, and especially breast cancer, there's just a big stigma. It's really uncomfortable to talk about. And unfortunately, a lot of us in the community have lost someone to cancer. So it's really scary. There's a lot of fear around it. So, some individuals might think if I just ignore it, I won't have to worry about it. It won't happen to me. Unfortunately, as much as we want that to happen, that's not the case. The best thing to do is, like we're talking about, get screened and get ahead of it, find it before it progresses to something that's harder to treat. And I think the biggest thing we could help with that is just to reduce that fear and reduce the stigma, especially in our own communities. Talking to people, talking to each other and your family is really powerful, and it's something that helps make us more comfortable. So maybe talking to your family members about, hey, did you get screened? Or asking them what, if anyone in our family has had cancer, and maybe you can know your risk factors a little better. And then just making it more normalized and making prevention a lot more of the focus, I would say.
And as I'm scrolling through our chat comments, we're getting great feedback. Carolyn mentioned some other barriers as being, and I think you've mentioned this too, but distance to getting screened. And from our research in rural communities, we know that your distance from cancer treatment, your distance from a cancer center can often be one of the most significant barriers in terms of outcome with cancer treatment. Fear, denial, COVID obviously was, I think, a barrier for most medical procedures, and actually you see an influx of folks who are now dealing with the repercussions of delaying treatment for various conditions because of COVID. Renee, do you mind maybe expanding on this notion of distance from the cancer center being a significant barrier, or your distance from testing or that sort of thing?
Of course. So distance being such a huge barrier, especially in rural communities. For instance, the rural community that I'm working with only has one hospital where you can only have so many procedures done, and to go from there, the distance jumps drastically. For patients to drive, they're very limited to choices of where they can go. It's either Olean, which is the community I'm working with, or they're making that drive to Buffalo, which for a lot of patients is a huge barrier. They're having issues with transportation, even just driving there. If they don't have transportation, asking a friend, can you drive me here? That's a long drive for anybody to, and so it makes it harder for the patients to want to get that screening done, because they're wanting to factor into that. I have to make the distance for this. This is really hard for us.
I think that goes along with that. It's not only a physically long drive, I think it's an emotionally long drive. And, I know that in previous conversations, it's really a significant cultural shock to come from a small rural or Indigenous community to a place, an urban area, a bustling urban area, and it's overwhelming. It's overwhelming to be in that situation to begin with, whether you're going for screening or treatment, cancer treatment, and to have a completely new environment, an overwhelming environment on top of that. And oftentimes people will shy away in favor of a closer, smaller rural clinic where maybe the care isn't as robust as it is at an advanced cancer center or a comprehensive cancer center. And that's something those are the conversations that we've had many, many times. Another barrier that Dr. Rubidoux had mentioned is that another significant sort of maybe a more clinical barriers, that the barriers are that screening mammography is regulated by the FDA, unlike other medical tests. So mammograms are only available at FDA certified locations and not everywhere, unlike chest x-ray, CT scans that you might find at your local hospital or health clinic. So that's another layer. It's another significant layer to add to this as well. All right. Covering a lot of ground, and I love how these conversations evolve from a general template into expanding on all these different ideas. And I think our audience is going to get a lot out of this discussion because this is, I think when we identify the barriers, we can create solutions to them. Obviously, the navigators are one significant solution that we've addressed. Our navigators go to the community. They're embedded in with the community. And so people who are interested in screenings don't have to go quite as far to find support, or they have somebody that's available for whatever additional services they might be. So all things considered, I think our navigators have the leverage to be able to fill in a lot of those barriers and gaps, and we're thankful for that. And the other thing I was going to mention was that this navigator program, which was alluded to in our discussion, was created from community interest. This was based on previous work by Dr. Herring and our team at CICR, which was spawned from previous research before that. And we found that there are significant gaps in terms of a person who is coming from a rural area to a place like Roswell Park for cancer treatment or cancer care or screening. And the notion was that there needed to be more support for people. And that's exactly what our panelists do every single day. And another question I have is individually, and I'm interested to hear, maybe we can get the whole group involved in this particular question. What has been your greatest success and greatest challenge so far as a patient navigator? And if you don't have any so far, because it's such a new program, that's fine too. But let's, Marissa, do you mind tackling that question?
Sure. So I think the greatest success, like Will said, this is a new program, maybe like 4 or 5 months old. Was honestly just launching the program and connecting with the community and seeing how much they appreciate it and how much it's needed. I myself work within the Cattaraugus territory community, so I had done a few outreach events and everyone was so glad that this service was available to them now, and they were really thankful because a lot of people do have cancer or have experience with cancer in the community and their families, and they just said, I wish we had this for a long time. When the time comes, I'm going to use it. And they were really interested in having those conversations about prevention, screening, all kinds of things like that. And it made me really excited because this is like the first program in the area at Roswell Park that's specifically tailored to the Indigenous communities. I think Will touched on it a little bit before, but coming into a huge cancer center like Roswell can be really, really intimidating. Also, just that burden of cancer on top of it. So having a patient navigator there with you is kind of a familiar face, more support. And that's really, really what people are appreciative of. And I think on the same hand, the thing that has been most difficult for me so far is just seeing how much of a burden cancer does have on the Native community. In this position, I've talked to a lot of people, and unfortunately I see more than I noticed before that a lot of people are experiencing cancer. So, that is hard to hear because it's people from my own community who I do know, but hopefully we can get out there and help them through their journey.
That's something I noticed as well. Before working at Roswell, I didn't realize how many people were affected, and humbled to a large degree that so many people often are struggling or thriving. Sometimes people are thriving during treatment or post-treatment, and we've explored in different ways in previous discussions why that might be. And oftentimes it revolves around family. The family unit seems to be quite strong in many Native communities, and that extra support assists people through the stress of the journey itself. So at the same time, I see it's easy to maybe be upset by what you're seeing. You're also seeing resiliency and strength throughout those challenges, and where people aren't necessarily suffering in silence. They found and not everybody, but many people have found ways to cope and ways to thrive through such extenuating circumstances. So it's at the same time, it's humbling and a little frightening. It's also inspiring to see strength within all that as well. Nancy, what are your thoughts on that? What has been your greatest personal success and greatest challenge so far as a patient navigator?
I think my greatest personal success, like Marissa's, is being a part of the team and watching the team grow and get out there and connecting with community members and sharing our knowledge. We work with some really brilliant people, and to be able to bounce knowledge off of each other and bring that back to the community is a huge success in my eyes. There's a lot of people out there that aren't aware of services that are available to them, and they don't know how to use their own voice. So, as a navigator, we're here to help empower patients to make those informed decisions for themselves. And I guess the biggest, what was the second part, the barrier?
Yeah, the challenge, the greatest challenge.
Probably the same in itself is getting to more community members, getting the word out there. I guess being able to, with COVID and everything, having more face-to-face meetings and events and spreading the word.
Yeah, and the navigation program was launched at a time when we're still in the midst of the challenges of the pandemic. So things are a little bit easier, but communication still has its challenges. And getting a program fresh off the ground, I would assume, this is just based on my observations. You are the ones who are the experts and have been in the trenches, so to speak. But seeing the challenges of getting out there, and this is definitely, I can say that every time I go in the community, all my conversations end up revolving around navigation and the service itself, and screenings, of course. But it's the fact that now we have this service, and we really want to, and we are. And maybe we can speak on, if somebody in the group wants to speak on the initiatives that the navigation program is taking to market the program, because I know there's some exciting things coming up. Things you've developed, ways in which you can promote and create an identity around the navigation program.
I'll jump in.
Yeah, go ahead.
I know many of us have been participating in outreach events within various communities. And I know there's been talks of doing, a short commercial skit involving us navigators in our sites where we're at. We're spread out through Western New York. So we're covering a lot of ground. So that's some good info to look into. And then we have our social media pages also. Our Facebook page is posting our events and our talking circles that we participate in.
And I believe there was development of a commercial. Is that correct? Or is that still in the works, developing a commercial that we're hoping to market to our communities? We have several Indigenous communities throughout New York State. We hope that that commercial reaches out to so more people are aware. Radio spots are in development. We've created pamphlets. Of course, we have social media, which is powerful in its own right. And admittedly, word of mouth, when you do outreach events, word of mouth travels really fast. And our communities, our local Indigenous community leaders are aware of our service, and we've had great conversations. And like I said, I think the interest is pretty self-evident because it was created in the community. This was created from those same conversations that we're all having, and people are, I think, open. They're open to this. It's a non-research based, and I want to emphasize that. Is the Center for Indigenous Cancer Research offers non-research related services to folks who are concerned about data collection, data sovereignty and such. It's strictly a free community service for people. And the contact information too. Let's briefly talk about that, because we want our listeners and future listeners to know how they can get a hold of one of the navigators at our program. So is there a phone number, website, email?
Yep, so I can talk to that. I'm stationed at the Chautauqua Center, that is Dunkirk and Jamestown, if you would like to reach out to me or if you're in those areas. And then my email is Chelsea, CHELSEA.redeye @roswellpark.org.
We also have a 188 number, that's 188 RP Guide. And that will connect you with someone who can go over screening questions with you and talk about your location and connect you with a patient navigator within your area. I am personally stationed at the Indian Health Services Lockport Service Unit. That's located kind of center between the Tuscarora and Tonawanda reservations.
So our navigators are, as I mentioned, they're spread all throughout Western New York. And they were essentially hired and strategically placed in areas they were most familiar with and had the most familiarity and I think comfort in the community itself. So that's essentially how we're linking patients up to our individual navigators, is based on location, and we have every area covered. So Marissa, what were you going to say? What was your?
Well, I was just going to add in, I'm stationed in the Cattaraugus territory. For people who aren't familiar, it's about 40 minutes south of Buffalo. So, that's the community I am from, and I'm working with people from that community as well.
Renee, what about yourself? What's your contact information?
My location that I work with is Universal Primary Care, and that's stationed in Olean, New York, which is about an hour 45-minute drive from Roswell Park. But it's very, being in that community, you can see what resources they have as opposed to what resources they don't. And that's where me as the patient navigator can step in and assist them.
Right. And for those who are not sure what RP Guide is, anybody that remembers the actual number itself, the long form of RP Guide. We're going to find that and we're going to bring it up. So if anybody can research it real quick or decipher the RP Guide, we want to make sure people, because we don't have old, the old spin dial telephones anymore. So I think people want to know the numbers they can punch in their smartphones too. So we do have a question in the chat box. Oh,
sorry. I was just going to give the number really quick. 774-8433.
All right. Again, for our list, 1-888.
Oh, sorry, I put it away. 774-8433.
Great. We have a really good question in the chat box, and I think our panelists can help us out with this one. The question is: have you worked with other established programs like that from the New York State Department of Health or the Cancer Services Program of Western New York, which also offers similar education and navigation to screening services? Does anybody work with either of those programs?
So personally, I'll answer. I haven't linked up with them, but it is a great opportunity for partnership. So I definitely jotted that down so that, as of tomorrow, I can start researching into it and link up with them.
I personally have, through a different program, through a colorectal cancer screening education program. I've worked with the Cancer Services Program. They're a wonderful group. They have several different offices and broken up by counties here in Western New York. And they're a fantastic group. And what they've helped, not only do they have several other partnerships, we co-partner on things and such, but for anybody who's listening in the Western New York area, Cancer Services Program offers free screening to those who don't have insurance, although that may be different, and certainly they offer educational opportunities as well. But for those who don't have current insurance, they offer navigation to various types of cancer screenings, free cancer screenings for people in need. So it's a wonderful service. It's a great partnership with what we do, both in the rural and the Indigenous communities. And
I just wanted to add that when we first started as navigators, we did a really, really robust training with some Native cancer navigation programs. It was actually two navigators that really started navigation in Indian country. So they were able to share their experiences and different methods they've used within the Native community, and they've been doing it for decades. So I think that was really important. And we're also in a monthly group that we share resources and stuff like that for Native cancer navigation.
Great. And for our panelists today, There is a link there in the chat box if you're interested in tapping into some of those additional resources. And I think it's probably, I don't want to say it's underappreciated, but I certainly didn't realize how critical partnerships were to driving these programs. You know, the grant programs that I've worked on, I wouldn't be able to function without my partners. We have wonderful partnerships. We're always interested in cultivating new ones, of course, but the partners we do have been critical to making any of these programs work. And in general, none of these programs work without strong partnerships. I have another question from Jessica. Is that monthly meeting an in-house activity, or is it an open to others outside of your program?
So it's actually, they actually just started it, I think, a month or two ago. So they're still trying to figure out how to structure the meetings. But we do meet with different patient navigators, actually from the US, Canada, New Zealand, and different places like that. So I'm not sure. I could probably find that out, but I know they're still trying to figure out the structure of the meetings, but they're all online and things like that.
And Jessica, if you're ever interested, feel free to reach out to me and we can link you up with those discussions as well. So for anybody else who's attending the discussion today, feel free to filter in your Q&A. We do have some time here to answer some of those questions. Marilyn, I think you're on, if you're still on the call, if you have any additional questions or anything that you want, actually, I'm going to go over some of, Marilyn, I don't know if you are available, but I can allow you to talk if you wanted to briefly discuss about some of the comments you made, because I think they're fantastic and they would really add to our discussion today. So I'm going to click allow you to talk. And if you want, feel free to chime in with some of your comments that you made earlier for our panelists and our attendees today. Okay. So I think we have another question. Okay, I scratched that. She's unable to talk on the computer, so microphone not be working. So yeah, anybody else who wants to feel free to chime in. I think in the meantime, I want to make sure that our panelists have adequate time to make any final remarks. Okay, any final remarks or ideas that may have been spurred by our conversation today. And we have a little bit of time left, and we'll make sure we address any of the additional questions we had. But let me I'll just start from left to right. Okay. Just see here. All right, I'll just start left to right. So Renee, do you have any final remarks or final thoughts or maybe visions of the future for navigation and maybe how you think the program will evolve in the future?
I think the program will evolve tremendously. I think that with having so many patient navigators in different rural locations, it will help, the increase in cancer screening. I think that is what's important, is that we're there to help, these patients that don't have the resources or don't even know that they have the resources available to get screening done. And not just getting to the screening, but just navigating them through that whole journey. I think us as navigators will have a huge push of what can be seen in the future.
Chelsea, what are your final thoughts? These are not final thoughts, just for today's discussion. Our thoughts in the future, but just for right now.
I think the program is going to expand and evolve, like Renee said. There's already people from the West Coast trying to talk to our program and seeing how they can implement a patient navigator program into reservations or communities like their own. And I just want to add, just ask questions. If you're a patient and you don't understand, ask a question. You have this panelists right here who are willing to answer any questions. You also have resources. So if you have questions, ask them. There's no dumb questions, because I know I will always have a ton of dumb questions. Don't worry about it.
Nancy.
Yeah, I think to add to Chelsea's is, ask the questions. Don't be afraid to, challenge your provider if you're not comfortable with your diagnosis, or don't be afraid to go get a second opinion. Don't be afraid to reach out for help. That's what we're here for. We're here to fill that gap of knowledge so patients can, make the right decision for themselves. There's a lot that goes into patient navigation, but for Indigenous communities, I think there's much more. Your navigator should understand the background, where your patient's coming from, and understand their way of life, I guess, the way they would look at a provider coming from that background. I guess that's what I'm trying to say. But yeah, like Chelsea said, ask the questions and break down that barrier, break the fear of getting screened.
Marissa.
Yeah, just building off what everyone else said, everyone had really good points. And I think, the navigation program is so new, but already just a couple months that it's been active. I think a lot of people are really interested in it and have been talking to us and really excited about what can happen. So, the goal of this program is to reduce cancer rates in Native and rural communities. So I think our main goal is just making prevention, screening, and education more accessible. Some people might just not come into Roswell just because it's so big and they don't know where to start, and it's just really overwhelming for them. So that's where we come in. We kind of make this a much more smoother and comfortable process. And I think just building the relationships between these Native communities and Roswell Park or the healthcare system is really what I want to see, to make people really comfortable. Like, oh, I could talk to Chelsea or Nancy or Renee, and they could give me any information about cancer. They can help me get screened or anything like that. So I think I'd like to see that in the future. And, this has a ton of potential to become that and even more. So I think as we keep moving and keep working, it's probably going to be a lot more than we even expected in terms of expansion and growth and things like that.
Great, thank you all. We have a question in the Q&A here. And it says, if you haven't addressed this already, what are some common questions or concerns, et cetera, you hear from cancer survivors? And what about caregivers? So what are some common questions and concerns you hear from cancer survivors as well as their caregivers? If you've had the opportunity to have those discussions, and feel free, anybody in the panel here, to jump in.
I haven't had I haven't come across a patient like that yet, but what we do offer are survivorship clinics, not just within Roswell. Us navigators have researched different survivorship clinics within our areas. So, if somebody's looking for, and not just for survivorship, other things, legal services and even food markets, healthy food markets. And a lot of us know where those, we all know where those are within each of our communities where we're stationed. So we can help you find those and, get you access to whatever you're looking for, basically.
I know one common concern that, generally speaking, not necessarily just breast cancer, but cancer survivors in general are saying is, I don't feel the same as I did prior to treatment. Fatigue, there's physical uncomfortable, undesirable physical manifestation post-cancer treatment. And that can be a common concern with cancer survivors following treatment. And so they're looking for answers and support in that way. And I know the Roswell Survivorship Clinic offers some support in that way to assist people who post-treatment their bodies are not the same. They may have other, like I said, manifestations such as neuropathies or very severe fatigue. Brain fog is quite common. And so, understandably so, that people don't want those symptoms. And so they're looking for help otherwise. And let's see. I wanted to, Marilyn, I see that you're on the panel. I don't know if you can talk or not. I don't think so, but I did want to go over one of her comments. This has been a very busy chat box today, so I'm trying to keep up with everything. And so one of the comments that Dr. Rubidoux had mentioned was there's a publication in 2014 by Tracy Onega showing that American Indian women have the furthest travel distance of any group to get mammography, ultrasound, or breast MRI, much further than any other ethnic group. So this circles back to a barrier conversation we had and ways in which our respective communities are trying to address that. One is by going into the communities, mobile mammography buses or patient navigators, navigating to the closest available clinic. And I know some of our indigenous communities, indigenous clinics offer their own in-house transportation service to address that barrier. And I think that's really important to discuss, because you wouldn't think that distance, I mean, maybe intuitively in the research world, we understand this, but I think the common person may not understand, well, it's not necessarily your ethnicity, it's not necessarily genetics, it's not necessarily your overall health, it's how far away do you live more than anything. And that's certainly a barrier that I think we can all put in perspective and help to close that gap a little bit. And I know there's rural organizations that don't necessarily serve indigenous people directly, but they have the exact same problem in the rural communities and the adjacent communities from our indigenous communities. Is the distance can be very crippling to your overall health. Okay. Another comment that Marilyn had made, and Marilyn, I think we need to discuss in the future having you come on and speak a little bit more detailed about your work. I think you have some great commentary and a plethora of research experience too. But she mentioned that there's another article in Cancer in September by Edward Hendrick about disproportional breast cancer in minority women under the age of 50, including Native American women. This makes mammography even more important to catch it sooner. So yeah, we can, these are all great conversations. I think it bolsters up the service that our navigators are providing and taking all this knowledge and figuring out, the respective solutions for these issues. And I think that, and I'm getting a little wordy here, so I apologize. I know our panelists have done a lot of the talking now, and I just wanted to say that each one of them does exceptional work and has an exceptionally difficult job to do. But the impact that it has or may potentially have is profound. And I hope that our panelists, if they're not aware already, realize how critical they are and how important they are to the overall health of the community. You have a direct impact, and research certainly can be impact, but oftentimes it's delayed and it's not always directly linked to the community. But you feel the direct pulse of your respective communities, and you have those conversations. You immediately link people up to services that could change their lives or certainly mitigate some of the stress. So it goes without saying that you all are critical, and you're really driving research to the next level that we do here. And really putting research in motion. That's sort of the way I look at the navigation program. You're taking all the figures that we crunch and all the focus groups that we have and all the conversations and all these grant proposals, you kind of all that wrapped into something that's tangible for our communities. All right. And I'm going to read another comment that Marilyn had said in the chat box here. And I'm doing my best to keep up and trying to mention each one of these, but so many appointments are needed for a breast cancer situation: a mammogram appointment, then a diagnostic mammogram appointment, then a biopsy appointment, and then an appointment with a breast surgeon, and then an appointment for excision, then appointments for radiation therapists, then appointments for actual therapy, and appointment with chemo doctor. So many appointments. And that's something I'm just learning now. I honestly had no idea that a simple mammography or breast cancer screening could turn into such a long process. And that only adds to the stress, I would assume, to somebody who's going down this path or experiencing this journey. Is, wow, we're really putting this in perspective. We're working up against the number of appointments and the distance combined, and we're compounding the issues. Really, really remarkable to think about, which there again just emphasizes the importance of all of our navigators and the work that you're doing, and also what we're up against here. And it's a challenge I think we're all up for. Does anybody have any final comments? I know we just had our final words here. It looks like we're winding down on time, and we've covered most everything here. I want to make sure we hit up as many comments as we can. Let me just make a quick sweep here to make sure I hit all these comments. All right. And so Marilyn did answer one of the questions I had earlier about why there's so many different recommendations, or why do organizations recommend at different ages and have different protocols. And it's really more just there's so many different medical organizations that have decided through their own collection of research and experience that recommendations should start at said age. And, you know, I think for navigators, it's probably a really critical element to how you're going about screenings and navigating people to screenings, is having that close contact with the individual providers, because one clinic may have different recommendations than the other. It may be nuanced, but nonetheless, it's always worthwhile to really have that close relationship with those clinicians, so we can have a better understanding how each community has different approaches to breast cancer screening. Okay. And a nice comment here from one of our attendees today, just said grateful for all you do, important work that you're doing. And I think we all can echo that as attendees, especially myself. Even I get a chance to work side by side with everybody in the group here, and always humbled by the type of work that they're doing, and grateful that in some way I can be part of that. And at the very least, we can, express the importance of the work and the work that they're doing, and more people can hear about the program. So I think we covered a lot of ground today. We answered some very poignant questions. We have contact information. We had experts on the experts in our attendee list today who provided some important additional context to the conversation. And moving forward, we are going to continue our monthly webinar series the last Wednesday of every single month from 3 p.m. to 4 p.m. Eastern time. We're going to have a collection of community experts, clinical experts, and everywhere in between to discuss all issues related to Indigenous health. So we thank everybody for joining our conversation today, and look out. If you haven't already, please you can sign up for future webinars through our website, which I provided in the chat box as well. And our website is going through a facelift right now, and the new version will have, the new website is going to have information about our navigation program. We're still working on the old version of the CICR website. Okay. And all right. So yeah, everybody, thanks for joining us today, and look forward to future webinars. Thanks, y'all.
All right. Thanks, Will.
Thank
care.
you.
Thank you.